Right. Hello, everybody. Thanks so much for having me. I consider it a great honor to be invited. You spot the gray hair. I'm probably the oldest guy in the room, almost, anyway. I'll just give you a bit of context. When I started my psychiatric residency, HIV had just hit Toronto, and Mount Sinai was the first hospital to open up a psychiatric clinic for HIV-related concerns. So in my second year of residency, myself and a fellow called Steve Wu were the only two doctors in the psychiatric clinic seeing HIV-related patients. This was like 1986 or 87, something like that. That clinic is now still going strong. There are 4 or 5 psychiatrists, 2 or 3 social workers. It's a burgeoning psychiatric clinic at Mount Sinai Hospital, so we still do a lot of HIV-related work there. My work has taken me over the years to medically and surgically ill patients in the hospital, including oncology patients. One of the things that kind of exposure to different disease categories, diagnoses, leads you to realize as a physician, as a clinician, is that there's a lot more about understanding the people that have the illness than perhaps about the illness itself. There are continuities across people's reactions to illness that is critical for helping them. And you can get a little lost in the weeds about the specifics of this chemotherapy or that antiretroviral or something like that. So today what we're doing is we're backing up to look at a particular characteristic of people's lives, which is adversity in childhood, to clarify what extent it impacts on the way they are ill, how they get ill, and how they cope with their illness, okay? So that's the brief. I'm gonna jump right in. I'm gonna sort of pummel you with some data at the start, just to say I don't have any conflict of interest. I'll show you a couple of books we wrote at the end, and if they made me enough money to be a conflict of interest, I'd be so happy, but they don't. We get some grant support from typical granting agencies as well. So we want to start with understanding what the rate of childhood adversity is. I appreciate this is a sophisticated population, understands a lot of this stuff, but it'll give us a base for sharing information as we go along. Appreciate the impact on both psychiatric and physical illness. Consider application of screening for adversity in childhood in your own practices, and a few words at the end about how we can approach this, which I think will be carried on by more capable people as we go through the day. So in the terms of the medical literature, ACE refers to adverse childhood experience, and it refers to a list of 10 things that was created by a man called Folletti. Folletti was an epidemiologist, who wanted to know precisely this question: how did early adversity relate to the presence of adult illness? He surveyed adults, not kids, and asked them about their childhood experience. Just to say right at the beginning, these are not the only adverse things that happen to kids. This is a particular list. You can argue about whether some of them should be on the list and other things should be included on the list. And in fact, there's a literature on that where people have expanded the ACE questionnaire to include other things which seem self-evidently relevant. But I'm going to show you a ton of graphs here, and I want you to know that this is the list that the graphs are referring to, okay? The other thing you need to know is that this is almost certainly an underestimation of anybody's personal experience. The way the ACE tool is used is it says a question like, were you ever touched inappropriately, or I can't remember what the wording is, but it's sexually abused. And if the answer to that question is yes, then you get a 1. Okay, doesn't matter if it happened every night of your life for 10 years, that's still just a 1. Okay, that's the same as somebody who had one episode at one time in their life. So there's a lot of detail that's lost in this questionnaire that as therapists and clinicians we would of course delve into. But it does nevertheless give us this foundation of information that we can work from to understand what's happening with the people we see. So we care about this because adversity is so common, because it's related to illness and risk behaviors, and because it makes treatment a bit more difficult for people. So let's go through these kind of one by one. This is Tracy Afifi's work. She's in Winnipeg. This is a survey she did on the general population that covered 24,000 people. And these are the rates that we find whenever anybody does a population survey in kind of Western cultures. There's essentially about a third of people that have grown up with some degree of abuse in their upbringing. It's gendered, and it varies a little bit across what people get exposed to what. But the, sorry, I'm trying to read and use the mic at the same time. Maybe I can move this way.
We're trying to get it handheld, John.
How about that? That might work better, right? Okay. So take home, adversity is not rare. Adversity happens to people, and it is a characteristic of people's lives that they frequently have to figure out what they're doing with their adversity. I'm going to give you some resources at the end. I'll just put this up now. We have the ACE questionnaire online, free, available anonymously for anybody to use. You can just go to this website and it'll ask you the questions electronically, and it'll give you your score, and it'll give you a sense of what that score means in terms of comparison to other people. So let's look at the data about relationship to illness. I'm going to show you 1 billion of these graphs. The point is not that you take in every graph. The reason I'm showing you 1 billion of them is to make the point about the shape of the graph and make the point about how consistent the shape of the graph is, okay? I'm afraid the numbers didn't come out quite right. All right, you get the shape of the graph, so, right? The higher the bar, the more likely the disease. The farther to right, the more likely there is adversity in the childhood. And this shows that with chronic depression, as you get more adversity in childhood, you're more likely to get more depressed. It stuns nobody in the room, right? It seems like a kind of a self-evident fact. Reflected also in antidepressant use. So this is follow-up 50 years after childhood, looking at whether the folks who did have that adversity and did have that chronic depression actually ended up getting medication for it. And indeed, the rate of antidepressant use goes up, depending on how adverse your childhood was. Again, I don't think most people are surprised that if shitty things have happened to you in childhood, you might have depression later in life. What I think does surprise some people is the extent to which the relationship holds for physical disease. So I'm just going to show you a few of those graphs to make the point. This is chronic obstructive pulmonary disease. This is the kind of catch phrase for chronic bad lung disease, and you see the same curve. By the time you get to 4 or more ACEs, you have 4 times the likelihood of having chronic obstructive pulmonary disease compared to somebody that had no adversity in their childhood. Stroke, 2.5 times. Hepatitis or jaundice, 2.5 times. It almost doesn't matter what disease we look at. That's the point I want to make by these multiple graphs. I could show you rheumatology, lupus, infectious disease. It becomes pedantic after a while, so I didn't want to do that. But it makes the point, right? Adversity in childhood, particularly more adversity, increases the likelihood of physical disease. Obviously, this applies to HIV as well. Here is data that looks at the rate of adversity in men and women with HIV. These are the men, and you can see that for sexual abuse, just use the top line, there is a 2.2 times likelihood that if you're male with HIV infection, you are twice as likely to have had adversity in the form of sexual abuse in your childhood, okay? That dotted vertical line is if there was no additional risk. So for all these different kinds of abuse, it's higher in the men, it's higher in the women, although the order is a little bit different. So if we look at the same kind of graph I showed you before, what we see here is that for HIV disease, where you have 4 or more adverse childhood experiences, it's 4 times more likely in men and 3.3 times more likely in women that you'll have sexual abuse, that you'll have adversity in childhood. Okay, so HIV is no exception to this. It follows the same curve as every other disease. This is some work that we did with the Ontario HIV Treatment Network, looking at how this relates in Ontario. And what you see here is the same curve. This is the proportion of people that do not have adequate viral suppression. And the more adversity they get, the more likely they are to have poor viral suppression. Okay? So people with adversity, more likely to get the disease, more likely to have trouble having their disease treated. Quick sidebar. I don't want to presume about the practice of people in the room. In my hospital, in a general hospital in downtown Toronto, I feel this data is absolutely critical data. Because what it means is that the people that are getting hospitalized are not a general population group of people, right? The people that are getting hospitalized with HIV disease or complications of intravenous drug use or just emphysema from their smoking and diabetes from their obesity and heart disease from their cholesterol are in fact more likely to have adversity in their childhood than the average person. So it's like if you see somebody with chronic significant disease, that's almost a selection for somebody that has adversity in their childhood. And you need to be thoughtful, obviously, about who that person is and what experience they've had in order to ally with them around their health care. That make sense? Okay. Somebody in the room might be wondering, how the hell do you go from adversity in childhood to lung disease? And we think this is the way it works. We don't have the study, the perfect study that shows it, but this is the current hypothesis, okay? And that is the same correlation we see between adversity and disease, we see between adversity and health risk behaviors. So the more adverse childhood experience you are exposed to, the more likely you are to be an adult smoker. The more likely you are to have sexual behaviors that expose you to health risks. And even in family practice at Mount Sinai Hospital, which is a kind of a pretty high SES, people have incomes, people are fairly well off in that family practice unit, we see that the folks that have adversity are more likely to be smokers, they're more likely to drink in a hazardous, unsafe way, and they're more likely to be heavier. Okay? The point of all these things is each one of those things carries disease risk. Okay? So if you have adversity in childhood and you're more likely to smoke, then of course you're more likely to get lung disease. You're more likely to get lung cancer, right? So we think that's the way it works. We think it works that way because, and again, this is kind of a hypothesis as opposed to proven. We think it works that way because in a family where a child is having a lot of adversity, again, a moment's reflection, you guys will appreciate this about clients you've worked with. It's not just that they have adversity in that family. It's that a lot of good stuff isn't happening, right? So nobody's loving them, at least not as much as in some other families. Nobody's teaching them that feeling in your stomach is butterflies and that's anxiety and you can actually be okay with that. You can manage that. We can work together to help you get through that. It's just the first day of school. The kid is left with unrecognized, unlabelable emotion and no good strategy for managing it. And people don't tolerate high levels of emotion that feel awful, right? None of us do. We all find some way of regulating it. And the big ways of regulating it that are available in our culture these days are smoking, drinking, using drugs, eating a lot of food, or having sex, right? So we think the way it works is that the kid who has the trouble with adversity in childhood doesn't learn good emotional regulatory strategies, doesn't feel like they can trust other people, go to other people for help, no shit, right? And so they turn to other strategies for helping themselves with their emotions, and those other strategies give them disease risk. Make sense? Okay. So I showed you smoking and drinking and stuff. This is alcoholism, intravenous drug use. This is the staggering statistic that comes out of the ACE study. Male children with an ACE score of 6 or more have a 46 times increased likelihood of later becoming an injection drug user compared with a male child with an ACE score of 0. I don't know of any risk factor for anything that increases disease by 46 times. I don't know if uranium does that with cancer, right? This is unbelievably high. Obviously, it requires our attention. One of the points I hope to make clear to you is that it's there whether you think it's there or not. Okay? People don't walk into your office or your clinic or your organization and say, by the way, I was maltreated as a child, so I want to talk to you about that. They come in with some other issue, right? And often may not want to talk about this, may not even recognize this as relevant to their situation. So this is data to try, a couple of slides here to try to illustrate that point. Here on the bottom, we see psychiatric diagnosis. These are patients that came to Mount Sinai ambulatory outpatient clinic for a psychiatric assessment. Typically, they're sent by a primary care doc. And the list goes from adjustment disorder, which is essentially the assessing psychiatrist thought they didn't really have a psychiatric illness, to mood and anxiety, which is kind of mid-level intensity psychiatric illness, to trauma, substance, schizophrenia, tough psychiatric illness on the right. So on these series of graphs, it's kind of less intense psychiatric disorders to more intense psychiatric disorders. And what we see is that the red line are the folks that have clinically significant adversity in their childhood, okay? So they have an increased likelihood of having a pain complaint or an opiate use disorder, no matter why they came to the doctor, okay? Yeah. This is a paper that I like to show, not so much for you guys, but for the internists at the hospital, because psychiatry can still be a little bit, like psychiatrists in the general hospital. So I like to show them this one because it's from the Journal of the American Medical Association, which is like as legit as you get in internal medicine. And it just shows the same data again. The vertical line has been lost. I'm sorry. There should be a vertical, you can just barely see it. It's there. That's the likelihood that these conditions don't have increased rates of adversity in childhood. All of them do. What are we talking about here? We're talking about the conditions that family docs in particular struggle with. This is chronic pain, fibromyalgia, functional GI disorders, irritable bowel disease, headaches, obesity, pelvic pain. Okay, so these are the kinds of conditions that people go to primary care docs with, and the docs never find anything wrong in the sense that they do ultrasounds or something. They don't find structural physical abnormalities. But the patients continue to suffer, and the patients continue to have distress, and the patients are more likely to have had adversity in their childhood. So one of the ways adversity shows up in adulthood is with hard to define for doctors, hard to define physical complaints for which there is no straightforward cause. Okay, let's talk about sort of what it looks like clinically, as it were. So here we have ACEs on the bottom, and we have degree of distress on the vertical axis, and this happens to be a cardiac population, but my point actually is it could be any population. And for equivalent levels of cardiac disease, the more ACEs you have, the more distress you're going to report. Okay, so just think about that for a minute, because the cardiologist thinks your distress is related to your cardiac disease. That's the premise they're working on, right? If you have less cardiac disease, you're better off than if you have more cardiac disease, so you'll be okay. Well, actually, there's another factor. The other factor is the degree of adversity in your childhood. And regardless of the level of cardiac disease you have, more adversity in childhood means you're going to have more trouble with your cardiac disease. You're going to have more distress related to it. Back to the HIV work we did. This is looking at socioeconomic status in HIV disease in Ontario. And here you see the social determinants of health. Health is related to education, employment, income. And as we go farther up the list of adversities, we see that the proportion of people that are okay with respect to those things goes down. So again, if you stop and think about it, it's not surprising, but it matters that we have proof. If you have significant adversity in childhood, it's hard to get a job, keep a job, get an education, stay in school, get an adequate education, and all those things play out over your lifetime. This essentially just says the same thing, that the level of functioning will be worse for people with higher levels of ACE. Okay. I don't know. Is there anybody in the room who saw me speak here years ago about attachment? Maureen. Okay. I'm going to give you just a quick grounding here. It's actually, I checked this morning, the presentation is up on the webpage, actually. You can go back if you're interested and you can see the attachment talk. Attachment is the relationship that a child has with their parent originally. And, you okay over there? Yeah. Okay, all right, sorry, I thought you were waving at me. Attachment is a relationship that a child has with a parent in the original instance, but as adults, we all form different attachment relationships. And attachment relationships are critical for regulating stress, for feeling comforted, for managing hard times in our life. And you can pretty straightforwardly divide people up into people that feel securely attached, kind of okay in themselves and okay in relationship, and people that feel insecure in the world. Either they don't feel like they're okay in the eyes of other people, or they distrust other people. Those are the two critical insecure attachment things. And there's actually a ton of literature, some of which we generated, but done around the world, a ton of literature that shows that insecure attachment is problematic in healthcare. It again is associated with higher levels of illness, but it's also associated with a tougher therapeutic alliance with your doctor. Because this trust element is challenged for these folks, it's harder for them to buy into the idea that the doctor is actually going to be helpful to them in a straightforward way. So one of the questions has always been, well, is that data on attachment? The folks that have insecure attachment and are struggling with disease, what's the story with them in adversity? Is the more adversity in childhood makes it more likely for you to be insecurely attached. So is the insecure attachment data just a kind of a proxy for the adversity? And people have looked at that, and sure enough, the folks that have insecure attachment are more likely to have been abused as kids. It matters a little bit what type of adversity you had. So where there's physical abuse, you're more likely to be classified as an adult in what's called anxious attachment, which is a kind of clingy, needy kind of interpersonal style. Whereas neglect leads to people being kind of purposely isolating. I'm fine over here, thanks very much. I'd just as soon not go to the doctor, that kind of thing. Both adult attachment styles, both adult insecure attachment styles will lead to more anxiety, more depression, and lower levels of self-esteem. So, and when we look at, in our data, how ACE relates to attachment insecurity, we see that, again, the same curve is there. The more ACE you have, the more likely you are to be insecure in your attachment. Okay? So this is very fundamental, guys. This is adversity messes you up in relating to other human beings. We focus in on the healthcare relationship. There isn't healthcare that doesn't happen in a relationship, right? You go to a therapist, you go to a worker, you go to a counselor, you go to a primary care doc, you go to a nurse, you go to a doctor. It's interpersonal. Sooner or later, it's interpersonal. Even when you go home and you take that medicine, it's so-and-so's medicine, right? So healthcare is obligatorily relational. So if we have a factor that impacts on people's relational capacity, it's bound to impact on their healthcare reception. And that's why it makes treatment difficult. So I put these things in so that you have the references. Let me just tell you what they say. What they say is that if you're treating somebody for depression and they have adversity in their childhood, you're going to have a tougher time treating their depression. They're going to have an earlier age of onset of depression. Their episodes are going to be longer and harder to treat, and they're going to have more recurrence of depression. And they're going to be tougher on themselves in terms of that depression. They're going to be more self-denigrating commentary. Maybe I'll just give a hint to this, and we can pursue it in the question period if you want to, because I'm not sure to what extent it's pertinent to you guys. It's also the case that it's related to mentalizing impairment. Now, mentalizing is a bit of a kind of a buzzword these days in psychotherapy. It essentially just speaks to the capacity to appreciate that you have a mind and the other person has a mind. Okay? So let me give you an example. I'm rushing to get here on time, and somebody holds the elevator door to slow me down. Okay? If I can't mentalize, I think, Jesus Christ, you son of a bitch, close the door. Right? Because they're just getting in my way, and I got someplace to go. I'm not attributing any cause or mental activity to that individual. If I'm even a halfway good mentalizer, I can say, well, I guess I need to talk to that person in the hallway, or I don't know, there's something important to them. And I start to imagine what's in the mind of the other person, right? Which means, of course, that I'm less stressed in the elevator, and I don't get my knickers in a knot about being a little bit late here, and everything works out being okay in terms of me getting here. So mentalizing is a capacity that protects you from stress and helps you in relationship, because you can imagine what's going on with the other person. Similarly, I might be able to say to myself, you always get a little nervous before public speaking. It's okay. You've left yourself lots of time, right? I can look at my own mind, as it were, and be okay with it. Part of the difficulty with adversity is that it impairs people's capacity to know what's in their mind and know what's in the other person's mind. And we think that's completely straightforward. We think it's because nobody was imagining what was in their mind when they were being abused, right? If you sexually molest a child, it's sort of obligatory that you're ignoring that child's mind, right? Because if you imagine the child's mind, it'd be a horrifying thing to do to somebody. So kids in those circumstances get the life experience of nobody considering their mind. They don't learn how to consider minds, and they're disadvantaged when it comes to living their life thereafter in some ways. Not by the way that people can't fix this, or that it isn't treatable, or that it's hopeless or anything, that it's a fixed quality. None of that's true. But it does, in fact, set people up a little bit. It also means that you're less likely to be treated effectively medically. This is HIV data again, and you can see the same old graph, which shows that the people not on antiretrovirals goes up with increasing levels of adversity. Now, maybe this is directly relevant to you guys. Maybe you have a cohort of folks who are struggling to take their antiretrovirals and you're not sure why. This would be a legit thing to try to pursue with them. This is population data, guys. We always do this thing, at least in medicine. At least in medicine, we do this thing where we split ourselves off from the population that we're studying, right? And we say, well, that's the patients, right? Is of course not. This is a human condition. This happens to everybody. The data we have on this locally is around paramedics. And here you can see that paramedics that have adversity, as in the red line, are more likely to have high rates of depression, they're more likely to have high rates of burnout, and they're more likely to have physical symptoms that interfere with their work. Okay? So being a physician, being a healthcare worker, in no way protects you from this stuff. Adversity is adversity. We're all human beings. We all have reactions to it. I'm giving you this data kind of piece by piece by piece to try to make a point. I think by the looks of you guys, we've made the point. This is the summary diagram that comes out of the Center for Disease Control in Atlanta, which means it's like prime time, right? And what you see here are various illnesses, conditions around the outside, and the line depicts the evidence for to what extent disease in those categories is accountable for by adversity. All right, and if you look up there in the your upper left, you see HIV, high risk, 60%. Okay, so adversity is highly relevant to most of the stuff we deal with, certainly highly relevant in the setting of HIV disease. And I think also to note that it's 40% of hopelessness. It's 70% of life dissatisfaction, right? It's not just illness-related stuff. It makes you unhappier and less content in your life more generally. So, ACE makes you sick. It makes it harder for you to function in your life. It increases attachment insecurity. It undermines trust. It reduces narrative coherence. I'll come back to that. It causes avoidance because it makes you want to stay away from people that you don't trust. It takes what is frightening and makes it traumatic because it evokes memories of past trauma. And it demands anesthesia. It makes you feel so uncomfortable you need to do something to reduce the intensity of your emotional experience, and that leads to substance abuse. The asterisks on narrative coherence, I'm sorry, I shouldn't have put something on a summary slide that I didn't explain. Narrative coherence is just what it sounds like. It sounds like, can you tell your story in a coherent way? Can you go to the doctor and say, I have this pain in my belly. It started last week. It was associated with diarrhea, but then I started to spot, and now I don't know what's going on. I got a fever, and that really worried me, right? If you go to the doctor and say that, the doctor says, well, okay, let's take a look, and they set about doing medical care. Somebody who has narrative incoherence goes, and the doctor says, so how come are you here? And they say, well, so my stomach hasn't been right, and I don't know when that started really, I don't know, but I got spotting, and the information does not come out in a coherent way because the person's scared, right? The person is not feeling comfortable with what's going on, and they're trying to anticipate how the doctor's going to react to them. And they tell a story that's harder to follow, and therefore means that their healthcare is impaired because of that quality of incoherence. So that's a clinical take-home. If you're talking to somebody and they're not substance abused, if they're not high at the time, and they're not psychotic, and they're not have some intellectually delayed, or they have some other reason for not being coherent, if they're struggling with coherence, I'd encourage you to think, this guy makes me scared. How can we help him with that? How can we settle down and try to get the story into some sort of shape that feels more reasonable? Okay, so now we're going to focus in on treatment is maybe a bit grand, but intervention, management, helpful strategies that we think are useful. And I feel obliged to say I'm operating from the level of a physician here. I don't presume about what is correct for your practices. I presume you guys will make a judgment about that for yourselves. I'll tell you what we say to docs, and you can take or leave what makes sense to you. The first thing we would say, though, is that you got to find some way of asking about this with your patients. Why do I say that? I say that because of this data. This is summary data from a lot of different studies. I want to emphasize the stuff at the bottom. The proportion of patients who want to be asked about physical abuse is 80%. The proportion of patients who want to be asked about sexual abuse is 70%. The proportion of patients who have been asked by their family doctor is 7%. The proportion of patients who have been asked about sexual abuse is 6%. So primary care docs if you ask them, if you look higher up, it says proportion of family medicine residents who believe it is their role to ask, 80% do, right? They've been educated. They understand this is a problem, but they don't actually ask. The patient would actually find it a relief to be asked and to be able to have this understanding between them and their primary care doc, but it doesn't happen. So you need to find some way of asking. And we've developed a resource for that. I think what I'll do is actually finish the talk and then show you the little movie if we have time at the end. If we run out of time, it's called the CARE technique, and there's a little video on YouTube that's at that URL. And we can show you that, okay? We'll probably be able to do it today. But the point being, figure out in your own practice how you want to address this issue, how you want to make it safer for patients around this stuff, and let's get some kind of strategy in place. Okay, treatment suggestion number 2, don't allow your reactions to run the show. We all are human beings. We all have our own reactions. We all have our own levels of adversity in various ways. And the truth of the matter is, even if it sounds unkind to say so, that high levels of adversity can make people defensive, so they can reject you as a healthcare worker. It means that remember that data, they're less likely to take their medicine and stuff, so they can be frustrating. Here you have a thing that can help with this illness, and you can't get the patient to do it. That frustrates people. So it's easy to have reactions to individuals that really distressingly confirms their expectation of the world, right? They weren't well treated when they were young. They come in to see the healthcare worker, and that person ends up kind of shrugging, I don't know what we're going to do with you now, kind of reaction. That's a problem. I think the solution to that is to understand that everybody's doing their best. And I also think that's the truth, by the way. Everybody is doing their best. And if they're in your office, if they're talking to you, if they're trying to sort something out, that's probably a really difficult thing for them to do. And we got to acknowledge that and start where they are and work with them to find some way to get them to the place where they can be maximally helped by whatever the healthcare intervention is. This means that your alliance with the patient is the first job. Nothing works until you have an alliance. Every now and then, a physician says the equivalent of, I don't need to be, they don't need to trust me, they just need to take the medicine, right? Something like that. And of course, it's exactly wrong, right? They're not going to take the medicine until they trust you. So you have to figure out the trust stuff in some way, right? And because the original experience of the adversity is characterized by distrust, if a parent sexually abuses you, that's a profound betrayal, right? So the idea that you're then going to go out in the world and trust people kind of just for the hell of it is less likely. And so if you feel with an individual that you're not kind of simpatico, you're not on the same page somehow, I'd encourage you to attend to that so that the contact with you can be as safe a place as possible, because it's that space in which you can then do the stuff you might think of as the healthcare work or something. I feel like I have to say something now that isn't on the slides, and I feel sort of awful it's not on the slides. Most people with adversity are fine. I've given you all this epidemiology showing the more adversity you have, the more difficult your life is, but it's not a guarantee. If you look at psychiatric illness, if you look at people that have ACE scores of like 2, the commonest adult outcome of that is that they're fine. The second commonest outcome of that is that they have a depressive disorder. The third is that they have an anxiety disorder. And the fourth is PTSD. Okay? So it's not that we're saying adversity ruins people. People are remarkably resilient. They manage all kinds of things in all kinds of ways. But it is the truth that the more that happens, the more likely they are to have consequence of it, and consequence that bears on their capacity to work in a treating relationship. Okay? So, you be person-centered as opposed to a doctor thing, which is you got an ache in your belly, I'll treat the ache in your belly, right? You figure out what the person's complaints are, what is it that they see as the problem, and you target the individual's function. When we have a lot of complexity, when we see folks that have 3 or 4 different diagnoses, where the guidelines for one disease are contradicted by the guidelines for another disease, and the care gets really complicated, there's a way of cutting through all the bullshit, basically. And that is sitting down with a person and finding out functionally what's going on with them, what do they need help with. And what you'll find out is that they can't get to the drugstore to get their methadone because of their mobility. And so they need help with their mobility, right? Don't worry too much about managing their diabetes. Help them with the mobility so they can get the methadone. And then when that's in place, they'll have a steady enough circumstance, they'll have a reliable enough living circumstance that you can start working on the diabetic stuff. That's the way you approach this stuff, I think. By all means, use techniques from other therapies. People often have specific training in other therapeutic techniques. None of those are bad for people that have adversity. Many of them are specifically helpful for people that have adversity. This is what your day is about, trauma-informed care. This is one list of characteristics of trauma-informed care, and you can see that they're all highly pertinent to what's going on here. Actually, I'll skip this in the interest of time. This is just an example from other literature that shows that even people with high levels of adversity, who have high levels of distress, can form relationships with a family care doc in a way that protects their care. Okay, there's another list. We put it, people like mnemonics, they like acronyms, so we put it into RESPECT as a way of helping people remember what's to go on. Dialectical behavior therapy is a strategy that's been well-researched for people with borderline personality and other conditions. And they have certain tenets that are particularly relevant to this population. This population is more likely to have a diagnosis in adulthood of borderline personality. That's helping them become aware of their mental states, developing emotional tolerance so that they can identify their feeling and tolerate their feeling and deal with their feeling. By self-soothing as much as other things. Keep them focused on the here and now. What's the problem today? Not what happened to you in the past or what the catastrophic fear is about the future. And to practice radical acceptance is their term for their circumstance and your acceptance of them. In attachment-based therapy, we would say that the therapist is the mechanism of the therapy. That the person needs a trusting relationship, and the trusting relationship you start with is a relationship with you. So as a therapist, you have to be, the phrase is a secure base. You have to be a reliable, consistent, ongoingly supportive, straightforward individual for this person to relate to so that they know they're going to get the straight goods from you. It doesn't mean you have to agree with them all the time. It doesn't mean you have to say they're always right. It's completely legitimate to say, some version of, well, you know, I have a patient who, prosaic example, but I have a patient who shoplifts, and every time she shoplifts, she increases the risk that she's going to be incarcerated because she really shoplifts. And it's a kind of a self-harm, right? So being a secure base for her doesn't mean telling her that shoplifting is okay. It actually means the opposite. It means saying, actually, that's self-harm again. You know, you're putting yourself at risk. Let's figure out why you put yourself at risk, why you're doing that. You have the choice, you know what to do to not shoplift, so let's get into that a little bit. Why are you choosing to put yourself at risk on this given day, right? And doing that consistently and reliably. Mentalizing is that thing I talked about imagining people's minds and the minds of others. And we do a lot of that kind of just like, so where were you at there? What was going on? What led you to want to shoplift, right? What did you think the pharmacist was going to do when he catches you 2 days in a row? Right? And you try to get the person to start to think of their mind, think the other person's mind, and work in that space. Narrative therapy, writing stuff down, is essentially a reflective exercise. There's fantastic literature on narrative therapy that shows that people with hypertension, rheumatoid arthritis, have lower symptom complaints if they write. It doesn't have to be about illness, right? And nobody has to read it. Just the act of writing is helpful for people's symptom counts. And mindfulness, of course, is ubiquitous these days. It's a way of self-soothing. It's many things, but one of the ways that it works is it's a way of self-soothing. It helps people feel contained. So, treatment summary, you focus on the patient's resilience more than on their pathology. You focus on their functioning more than their symptoms. You do what you can to help them develop narrative coherence. You do what you can to help them develop emotional tolerance. And you delay any specific intervention until you have some level of trust established with your patient or client. This is a complicated diagram, but it sums up an idea I want to leave you with, which I said at the beginning, which is that adversity is a cause of causes, okay? This is from HIV disease, again, on the far right. And you see adversity on the left. And they did this complicated statistical analysis which showed that there's a relationship between sexual abuse and substance disorders and HIV, right? It goes that way. So the adversity is something that creates vulnerability in individuals. It leads to them having health behaviors, which then leads to them having illness. So it's a cause of causes of illness. And that idea is a helpful one, I think, to have in mind as you work with your clients. So, wrapping up now, and we'll have just a quick chance for chats. That's the ACE calculator. That's the website about ACE that we've just got up. This is the care method. This is the way you ask about adversity, and it's on the table. And we suggest that you establish a consent with the individual to ask about it. You then find a way of asking that feels comfortable in your own mind and practice. You reflect on it with them, and you engage in what further steps you want to go on. The video takes you through that in a more kind of straightforward way. The self-assessment is available to anybody who wants to go there, patient, client, anything. It's anonymous, it's free, it's valid, and you can measure anything you want and get a printout that tells you how you're doing. That includes the childhood adversity score. It includes a traumatic events validated measure. It also includes an attachment measure if you want to look at that. So you can do that for yourself. Sometimes you can do that with patients. I actually use it to follow some patients serially in terms of depression scores and stuff. This is the disclosure book. These are 3 books that I've contributed to about attachment. The one on the left is meant for an audience like you guys in terms of its kind of style of writing. The one on the right is more kind of a textbook. And the Achieving Psychotherapy Effectiveness is specifically about psychotherapy, but it addresses trauma and attachment in it. Claire Payne, a colleague of mine at Mount Sinai, wrote this book a while ago, which specifically addresses these issues that we're talking about. And I'll leave it there with this other kind of summary for you. Thanks very much, guys.